it's time to get started with our clinical topic. And today's speaker is Dr. Meghna Dassani, who is in private practice in Houston, Texas. She received dental training at the University of Mumbai in India, and then received her DMD from Boston University. And for the past 17 years, her practice has focused on treating patients with sleep disordered breathing. She's the author of 2 books on sleep apnea and the dental practice, Healthy Sleep, Happy Kids, and Sleep, Breathe, Dream. She spoke for our recent sleep symposium, and she confided in me that her superpower is practice implementation. And it's not often that we get somebody that can come and speak with the ability of a superpower. So I'm pretty excited to bring Dr. Dassani to you. It is all yours.
Thank you, Dr. Park. Yes, I will unabashedly admit to that being my superpower. As anybody knows, every time we go to any new CE that we're super excited about, I don't know about you guys, but I'm one of those that's constantly texting. I was texting my team while we had the other panelists dropping their ideas too, about what we need to purchase, what we're going to do Monday morning, how things are going to be different on Monday. And it got to a point in my practice that initially the team would be, yes, we're going to do this, we're going to say this, we're going to do this differently. And then Tuesday afternoon or Wednesday rolls around and we're still doing the same thing. And the team got to the point where they're like, yeah, give her a day. She's going to go back to how things used to be. And I realized that a lot of it comes from having systems in place that are consistent and replicable. And by that, I mean, you could have a new, and I'm fond of saying this, anyone, if you could walk into my practice, pick up my systems and protocols, and it might take you 3 times as long to do things just because you're new there, but you'll get it done and right the exact same way. And that is where success in implementing something effectively that's new to our practice comes in. I'm going to go ahead and share my screen while we do this. To having protocols, it all comes down to you knowing what you're going to say, how you're going to say it, and your team being able to pick that up by hearing you say, do, follow things the way they need to be. What is the missing link in implementing anything new within the practice? It's just that. It's the fact that it's new. It's unknown. It is a lot of times scary, and a procedure such as sleep, implementing sleep dentistry within your practice, I find, and when I talk to so many doctors, dentists, team members too, on a daily basis, and most people have been through trainings, have learned it, and at some point got off track because they just could not seem to get it together. Because let's face it, when we are treating sleep apnea within the practice, we are treating a medical procedure, are we not? There's no picking up a drill and removing X millimeters of tooth structure with a certain box form with angles of X degrees. We're treating a medical condition. Yes, we have a dental solution to be able to treat it, but our thought process has to change. A lot of times the billing has to change as well. And for team, this is something entirely new, which is why of my top tips to implement sleep successfully, effectively, and consistently within your practice, I say your team is your strongest point, link in getting this to where you want it to be. Sleep is a completely team-driven procedure. As long as you can get your team trained and pulling in the same direction, because ever been in that boat? And I say this in the practice with a procedure that you wanted to do. And as doctors, we're like, we're going to do this. We're going to do photos for every patient, and we're going to do Facebook transfers. We're going to do impressions, and we have this list of things that we want to do. And the team goes like, are you kidding me? This is like a whole day's worth of new things we got to do. With sleep, what I find is when your team isn't talking, isn't educating the patients, isn't answering their questions, a lot of it comes from not being confident in what it is that you want them to say, and also in the knowledge that they have. I will not speak about a procedure, a process, a technique if I'm not confident, if I'm not 100% sure about it, because I don't like to look or feel stupid. And I'm sure this holds true for each and every one of you as well. And I know it holds true for the team. Ask me how I know. When we throw our teams into something because we're so super passionate about it, because we know we're going to change lives, it's going to increase productivity, you just don't have the backup of the team, the support of the team. It's because they don't feel like they have all the information that they need. And that's where you'll start to have teams start to drop off, not speak about it as much. So getting your team on board is key. Give them the education that you have. Simple things. Set aside an hour each week at lunch. I don't know, order pizza, everybody bring their lunch, however it is that you do team training in your practice, and educate them about what it means. What are the common questions they're going to get asked? What are the answers that patients are expecting, or what is the knowledge that they have about it? So I'll tell you, one of the most effective things I did to not only get my team to be able to start speaking about all of this, but also to raise awareness with my patients. Because, you're a dental practice, we still drill, fill, do everything. I'm fond of saying I do the best buccal pit composites of anybody here. Life still goes on, right? We put up little posters in the operatories. We've all done this, right? Any procedure that you do, say you're starting to now offer brooks or crowns, you have that poster in your operatories, or anything new if you're offering ortho or clear aligners or whatever that procedure may be. Well, we made up posters. I made the poster. You don't have to do anything fancy. Just get on Canva and make it. That said, do you snore? Ask us for more information. This is literally what it said. And I found most patients asked questions, not when they were in the operatory, not when they were in the waiting areas, because if your practice is like mine, I don't want anybody in my waiting area. But doesn't every patient visit the bathroom in the office, or at least most of them do? And we had a poster right across on that wall. And we had patients would come out and ask my front desk. It's like, hey, John, like, what's that about? Why is Doc talking about snoring? Why is she talking about a CPAP? Let's think about this. If John didn't know anything about sleep apnea and you start this Monday morning, your team's not going to know everything about it. John gets to tell them, that's a great question. I know she's getting more training on this. I know she just went to this amazing CE. Let me make sure they give you the answer for this. Let me write Doc a note to make sure that she answers your questions. I just empowered John to say, I don't know the answer. I'm going to get it for you, though. But at some point, I want John or your front desk, whatever their name may be, Sally, to be able to answer this question. And most of us, even our team members, even our patients, have somebody in their life, be it an adult, be it a child, that snores, that suffers from either has a CPAP, cannot use it, is tired all the time. They probably have a child that mouth breathes. Check some of those boxes. When your team completely understands what it is that they can do to help this patient, they take this. In my practice, sleep is my team's legacy. It's not mine. This is something they have taken and they've run with it. It starts with you and I getting them the education, the knowledge that they need to understand what it is and to be able to have knowledgeable conversations with patients without feeling like they're messing things up, because God forbid, right? They're scared of disappointing us or worried that we're going to get upset, and also feeling stupid. This is what a workflow for sleep in your practice should look like. You are not even in the picture. Your and my superpower with regards to sleep comes into doing that examination, picking what appliance. If there are issues that happen with appliance use, being able to address that. As dentists, we are not allowed to diagnose sleep apnea. That is outside the scope of our practice. This is why we have to work with our MD colleagues. But to keep everything moving smoothly and making the puzzle pieces fit, that's entirely up to the team. From coordinating referrals with other professionals, be it your myofunctional therapist, be it your MDs, be it other dentists, or however it is that the patients find us, to taking in information, to your hygienist having conversations with the patient, to your front desk, be it Christina, be it John, whoever that is in your practice, saying, my dad had a CPAP and doc made him an appliance. Who does our patient turn to when I say, this tooth needs a crown, I give you all the information and I walk out? Don't they turn to whoever's presenting treatment, to the assistant or the treatment coordinator, go, do I really need it? Tell me more about this. What is it going to look like? How long before it's going to come back? Is it going to hurt? When that team member is able to sit down and have this conversation with the patient about, I had a sleep study and this is what it felt like. My dad had to have a sleep study at the lab and it was all these wires. If you're in a state that you can do HSTs, home sleep tests, maybe that is something they're going to be able to ease their worries about. If it's a child, my child needed this, or we see other kids, or she was able to help my dad because he could not use a CPAP. That instant human connection is all that the patient is asking for. And that's what allows it to run like a well-oiled machine. What are some things we can do first thing Monday when you get into the practice? Most of us are now have programs, right? The software that allows us to update our health history for the patients, going in and making changes, adding these questions. Do you snore? Do you grind your teeth? Clenching and grinding can be your body's reflex to open up the airway. A muscle that is relaxed occupies much more space than a muscle that is tense, does it not? Which is why, as women, we all pose with our arm propped up. It makes my arm look skinnier, does it not, in the photos? That's exactly what that patient is doing. Clenching and grinding, tensing those muscles to open up the space here. When I have yeses to any of these, I know I can go back and start to connect the dots for my patients. Do you wake up tired or unrefreshed? If you have a child, well, even adults, I'll have patients that go, oh, I woke up on the wrong side of the bed this morning. Well, there is no wrong side of the bed. It's just that you haven't gotten either enough hours of sleep or good quality sleep or both. And which is why your brain hasn't been able to heal. Have you been told you choke or gasp for breath while sleeping? Anybody that's anybody, if you've ever watched a video on it, know a loved one that does this, it is scary. It is watching these people come up for air. And it's not pleasant to observe. So you can only imagine what that person is going through. Do you have morning headaches? Most of us think you wake up with a headache in the morning, it's because you're clenching and grinding your teeth, which it could be. But when we further elaborate upon this question, if you have a patient that says, or if you're my doctor and you say, hey, Meghna, do you have morning headaches? And I go, yes, doc, I do. I certainly wake up with morning headaches. And then your next question should be, how long does it take for it to go away? If I have a headache that starts to go away as I wake up, I know that that is from lack of oxygenation or not enough oxygenation to the brain. I'm now awake, upright, breathing. I am reoxygenating, and my headache starts to go away. That's one more box that has been checked that I know I can now start to have this conversation about sleep issues with this patient. And then this is my favorite. Do you wear a CPAP? When I started to treat sleep in my practice about 10, 11 years ago now, that exact question, right? Do you have a CPAP? Well, because in my head, I thought this patient took the time, the effort, and spent the money to talk to their doctor about it. Then they went and got a sleep study, which is like they spent the night in the lab. They got fitted for a CPAP. They paid for it, right? Surely they put it on. Little did I know. 68%, 70%, that number changes every time I turn around. 68% of these patients that have a CPAP are unable to use it. They can't tolerate it. They choose not to use it. They can't find a mask that fits the way and seals the way it's supposed to be. The reasons are endless. So I've now learned to ask a patient, do you wear a CPAP? You could have a CPAP, it's sitting under the bed, sitting in the closet, in the garage, the stories I could tell. But do you wear a CPAP, which means does it get on your face and does it stay on there? When I have patients that check these boxes, I know to dig a little deeper. And then we start with screening patients, right? This was just part of our medical history or our intake form. And we ask all of these other questions as well when we are in our health history. You ask for history of hypertension. Do they have a diagnosis of hypertension? You know, I've learned to not just take blood pressure and leave it at that, because if they're controlled with medication, they may fall within normal limits, but they do have hypertension. So have you been diagnosed or are you taking medications for hypertension? A patient that needs more than one drug to control their hypertension needs to have a sleep screening. I didn't make this up. The cardiologist that refers patients to me said this. More than one medication. Think back at the patients you saw last week that needed more than one drug to control their hypertension. We need to talk about getting a sleep study with these patients, get their sleep evaluated. Diabetes. Patients with diabetes are 15% more likely to have OSA. Or you can flip that around. Patients with OSA, 15% more likely to have diabetes. And then there's the third, high cholesterol. My cardiologist and I call that our holy triad. If you have a patient that has hypertension, diabetes, and high cholesterol, they've either marked off on it or they have the drugs that they take for it. You know, sometimes they have diabetes and the doctor wants to try something different, or the patient says, I'm going to control my diet and exercise and see what I can do for my cholesterol, but they know they have higher numbers. If you have that holy triad, get a sleep evaluated, get a sleep study done, talk to them about sleep. If you're in a state that allows HSTs, consider, being able to send them home with one, or send them to a sleep lab, or get on the phone with their MD and say, let's get their sleep evaluated. Depression is a big one in my practice. Patients that are on antidepressants or the anti-anxiety medications, we all know we have these patients in our practice, do we not? The antidepressants are shown to decrease REM sleep. We're going to go 2 steps back and talk about types of sleep. We have REM as well as non-REM. Non-REM, non-rapid eye movement, that is when your body heals, body goes into the body shop, the healing, the rest, the repair, the rejuvenation, that's when all your neurotransmitters are topped off. And then you have the REM sleep. REM sleep is when actually your brain is healing. So antidepressants decrease REM sleep. These patients are caught in a cycle, are they not? They went to their MD, they had the symptoms that their MD determined they need these medications, which outside the scope of my practice to determine whether or not they need it. But yes, they need the medication. They put them on these medications to help them feel better. And then the patient goes back for a follow-up in 2 months, 3 months. And the doctor asks them, how are you doing? How are you sleeping? How are you feeling? They probably don't ask them, how are you sleeping? And the patient says, doc, I feel a little better, but I'm not quite where I thought I would be. What does the doctor typically end up doing? Or what do these patients end up getting? A second drug, do they not? Or maybe it's just my practice. They end up getting a second drug. Now we have medication that they need, which is still decreasing REM sleep, which is what the brain needs to be able to rest, to heal. And they're in this cycle. The medication is needed, doesn't get REM sleep, their brain doesn't get the rest it needs. And we're in this spinning wheel. Ever had that happen on your computer? And that's exactly what's going on with these patients. So when you see these patients that are on these medications, talk to them about their sleep. Ask them, how are you sleeping? Do you wake up? Do you wake up feeling rested? Talk to their MDs. Let's get their sleep evaluated. Then we have GERD and acid reflux. And I don't mean the one time you went to get Mexican food at night and then you ate tacos and had margaritas and chased it down with some beer. That's not the acid reflux I'm talking about. This is somebody that cannot survive without their medications, the Nexium or whatever, Tums or whatever it is that they have to take to manage this. And it is ongoing, it's chronic. What is sleep apnea, right? Sleep apnea is when a person lays back, the tongue falls back, the muscles relax, and there is a complete obstruction of the airway, right? At that point, the heart goes, well, there's no newly oxygenated blood that I need to take to the rest of the body, to the brain. And the heart slows down. And at some point, the brain says, dude, wake up. I need oxygen. So now the heart is ramping back up, trying to get enough oxygen to the brain. And this cycle happens over and over and over again, all night long, multiple times, right? Well, just 2 minutes ago, I said, non-REM sleep is when all the healing and the rest and the repair and the rejuvenation happens. That's when the body is going into the body shop. Well, I guess the heart didn't get that memo, did it? Because it's working harder instead of healing and repairing. This is why these patients are at a higher risk for stroke. This is why these patients are at a higher risk for hypertension, cardiac disease. In the effort to actually get more oxygen, the choking and the gasping, think back at the symptoms, the questions we asked in the previous slide, that person is coming up for air. You have a complete obstruction in the back of the throat. You're trying to draw that breath. That creates a tremendous vacuum, a suction in trying to get that breath in. And a lot of times that pulls up the stomach acid. And that constitutes the acid reflux for these patients. Let's also think of what's happening with that acid hitting the inside of the esophagus. What happens if I were to get a burn? There's inflammation, is there not? Healing happens with scar tissue formation. Inflammation takes up space. Scar tissue is much thicker and takes up space as opposed to regular tissue. Well, we just effectively allowed the body to heal, or even with the inflammation, in a way that that already narrow airway is getting narrower. These are cycles that continue, and all they're doing is addressing the symptoms. This is where you and I, this is your superpower. This is my superpower. You and I get to take this knowledge, connect the dots for the patients, and we haven't even looked in their mouth yet. Their mouth is going to tell us a whole different story. And I tell patients this, I can look at this and tell you, there's a very good chance you got sleep issues going on. Prior orthodontic treatment, if we see premolar extraction in itself does not cause sleep apnea. But when we're trying to close the spaces, we're retracting everything, takes away tongue space. The tongue has nowhere to go but fall back. And I always laugh. It's like trying to fit me into size 0 jeans. It just ain't gonna happen. And those are things to keep in mind. Insomnia, it is the single largest disease state in the world at this point. And a lot of times it's often a symptom of what's happening at night with these patients. So the more questions we ask, the more details we draw out of patients, because let's think about this. Why are these patients going to want to sit and talk to us about this? Because, doc, you didn't talk about it until last time I saw you. And what's new? What's new is that you and I now have more knowledge to be able to pull this out, this information out. And it can start with, yes, we changed these questions on our health history. We're now having these conversations. You're looking at the yeses marked, and you're starting to connect the dots. I also have patients fill out screening forms, screening questionnaires. The Epworth is one. This is what I use in my practice. It's just something that my sleep MDs and I have come up with. You come up with your own protocols and systems for what's going to work best when we're communicating with each other. And I love this because this is the patient grading themselves. They're scoring themselves. I'm not telling them they're sleepy. They're telling me they're sleepy, right? It's like, hey, Mr. Smith, what are the chances of you dozing from 0 being I would never ever to 3 being a high chance of dozing off when you're sitting and reading, when you're watching television, sitting inactive in a public place, such as a theater or a dental meeting, as a passenger in a car. If you're sitting and talking to somebody, sitting after lunch without alcohol, we're not even talking about alcohol here. In a car when stopped in traffic, that is scary. You start to screen enough of these patients, you'll notice how many people say yes to this. But of course, 50% of my practice is sleep. I'm still a general dentist, by the way. I still treat everything else. But when we have patients come in for sleep, it's not uncommon. We're scanning. Before we had a scanner, we'd do impressions, and I'd hear the assistant like yelling, open, open. I was like, why are you yelling at the patient? Well, I'm yelling because they're closing because they fell asleep and now they're biting my fingers. People doze off in the dental chair, do they not? But if you're falling asleep and I'm drilling on a tooth or doing impressions or a scan, that might be a problem. So the patients fill this out along with when they're updating medical history. They add up that score, and if it's 9 or more, we got a problem. This is when they get to talk to me, they get referred out to the sleep MD for a sleep study, or I encourage them, talk talk to your doctor, talk to your MD. I'll be honest, I have never been asked about my sleep at any of my well checks, be it my annual visit with my MD or even my well woman check. Never been asked. Now, my dentist does ask me, and I see my dentist more often than I see my MDs. I only see them once a year, thank goodness. I do the screening every time they come in for their hygiene appointment, be it every 3 months, every 6 months. You choose the protocol you want within your practice. The reason we do it is because a lot of times patients like turn appointment days into, this is my doctor day. They'll see us and then go to their cardiologist and go to their MD and then their ENT, and then things have changed. And I want to know if anything has changed because they don't always remember to tell us. The stopping is another screening questionnaire that is very popular, does give a lot of information as well. I personally don't use it. Like I said, with my MDs, we've come up with, we're going to use the Epworth, but it stands for S is for snoring. Do you snore loudly? Yes or no? The patient knows that. Are you tired or sleepy? Has anybody observed you stop breathing during your sleep? Do you have or are you being treated for high blood pressure? These are good ones. And this could just be a main thing, but these other 4 questions are the ones why I find myself gravitating away from this screening tool. The BMI, what is your BMI? I don't know. I don't know my BMI. I don't even want to know it, right? So that is an automatic, who knows? Age over 50 years, these questions I feel are skewed more towards, your classic sleep apnea patient is the adult overweight male. And now as we learn more and there's more awareness, we know that's not true. Children could have sleep apnea. A slender, fit female could have sleep apnea. An active, not overweight male could have sleep apnea. And there is no age or gender restrictions to it. So when I say age over 50 years and the patient says, no, that's automatic, am I excluding the others? And that's one of the things that I feel I'm not screening them. Neck circumference greater than 16 inches, yes. For males, if your neck circumference is greater than 16 inches, higher chance of being positive for sleep apnea. But the men in my life don't know what their neck circumference is because it's me that does the shopping. It's my mom that goes buy the shirts, or it's the women in their life that probably know much better. I don't know what my neck circumference is, by the way, but I do know what my brother's is, what my dad's is. And again, that excludes a lot of things. And then gender male, same thing. We know that females could also be positive for sleep apnea. Hence my preference for the Epworth. You choose one that fits best with your philosophy, that fits best with how you screen your patients. Screen your patients. When you get yeses to any of these questions, you know to ask more questions. If you take one thing from today's presentation, take this. Every team member asking every patient, how are you sleeping? And I tell hygienists when I speak with them, we talk to our patients about brushing and flossing, but there's only so much that we can fuss at them for not brushing or for not flossing or for plaque around their teeth or whatever it is that we yell at them for, or not yell, scold them for. After that, conversations usually revolve around, in my office, graduation. I have a senior that's graduating end of next week, or summer trips or camps or the Taylor Swift concert, right? If we at least ask this as one of the questions in the conversation that we're having with our patients, this opens up doors for the patient to share information with us and for us to be able to get an insight. So we had a patient where it's like, hey, Sally, how are you sleeping? And doc, I sleep fine, but my husband snores so loud. Like I have him sleeping upstairs in the bedroom at the other end of the house, and there are still some nights where I can hear him snoring. Or my daughter was grinding her teeth so bad last night, she woke me up. Or the puppy got into bed with me. Or I don't know, I wake up every so often and I can't go back to sleep. You get an insight into what is truly happening with their sleep. And it allows you to guide conversations into, well, have you had a sleep study? Oh, yeah, doc. They gave me one of them CPAC things and I can't use it. And then it allows you to tell, did you know I can make you an oral appliance that's going to help you keep your airway open? You see where this goes without me trying to sell a patient something. I know it's important for them, but I'm also allowing the lady who told me about her husband. The husband is not or was not a patient of the practice, but he did end up coming in to get an oral appliance made. When we ask these questions, when we observe the things that's going on, when I look inside their mouth and I see the wear from clenching and grinding, when I see the scallop tongue, by the way, a scallop tongue, 85% of those patients are potentially positive for sleep apnea. It is considered a marker for OSA. When I look at everything that's happening on their health history, in the conversations with the patients, the medications that they're taking clinically, what it is that I'm seeing. Do they have teeth extracted? Are they missing teeth? Do we have a lot of where they're closing down? Is there lack of vertical? All of what does the tongue look like? Are there tonsils? Are they constantly stuffy? When I can connect the dots for these patients, it gives me an insight along with being able to educate these patients. I can now sit this patient and I say, hey, Jake, I'm seeing wear on your teeth. You said yes to clenching and grinding. You also said yes to snoring, whatever may have been checked off. This is where I get to educate them about bruxism. Did you know clenching and grinding could be your body's way of opening up your airway? A muscle that is relaxed occupies more space. So when you're falling asleep on your back, probably everything's relaxing, causing an obstruction, and your body's just trying to open it up, man. I don't know. Have you had a sleep study? Let's see what's going on. And I am the one that always throws me under the bus. If you have stories to share, family members, loved ones, share them. I've lost a brother to sleep apnea. So I am out there sharing this story. And when we're able to connect that for our patients, it makes us real. Because otherwise they think we're perfect. A dentist can never get a cavity. Ha, little do you know. Good thing you don't get to look inside my mouth, right? We get to educate them on the health effects of sleep apnea. This is something I made in Canva. If anybody wants this, please send me an email. I'm happy to send it to you. I've used it as an Instagram post as well. Grab it off of my Instagram. I'll willingly take my name off of it. You can use it as your own. But turn this into a poster. Put it in your operatories. Puts you at a greater risk for heart attack, stroke. We talked about diabetes, hypertension, depression, right? The medication. Side effect is less REM sleep. Memory loss. Alzheimer's is it's a well-known side effect of OSA. When a person does not get into deep sleep, does not stay in deep sleep long enough, the beta amyloid that collects intercellularly in the brain poop, as I call it, doesn't get cleared out. And beta amyloid has been shown its connection with Alzheimer's, dementia. Are we not seeing more and more early onset cases? It's not because the world is evolving. It's because of how humans are evolving. And we're now seeing sleep issues in our children, and they carry this over into adulthood. There's more and more amyloid plaque that gets collected. And at some point, it tips the balance. Daytime sleepiness. Do you want to be on the road next to an 18-wheeler where the driver's fallen asleep? They thankfully all have to get sleep studies for their commercial driver's license now with DOT. Or on an airplane with a pilot that is sleep deprived. Or do you want to be the one that is sleep deprived driving your kid to school or to tennis or piano? So these are the questions that when we ask and the answers that we get, we know what we're helping our patients with. And as I was saying, I like to throw myself under the bus, and I tell my patients this: when I see all of these signs and I can connect these dots for you, I'm going to tell you, hey, let's have a sleep study done. I would rather be the one where your sleep study comes back as everything's fine, and the sleep MD says, and you say, God, Dassani worries about every little thing. I'd rather be that and go like, yeah, what can I do? I like my patients. As opposed to your family member having to call me and say, something bad happened. They had a heart attack. They had a stroke. That's what happened with my brother. He didn't wake up in the morning. He had every possible appliance he could dream of sitting on his bedside. He had a CPAP too. I mean, he didn't have to pay for any of those, right? But his consistent answer when I was like, put your appliance in, put your CPAP on, was, well, daddy snored. My dad snored growing up. Thank God we still have him. He'll be 78 this year. Daddy snored. He's just fine. Yes, he is fine. So he never took it seriously. He never wore his appliances, never put a CPAP on. And every time I fussed at him, it was like, I have a wife. I don't need a second one. Don't nag at me. Well, he never woke up one morning. So I'd rather be the doctor that worries about you than the doctor that has to hear about this. And I encourage you to be that doctor too. It's well worth it. This was just a dramatic slide I found about clenching and grinding, but we get to have these conversations with our patients, just educating them, encouraging them about this is what I'm seeing. When I see enough of these, and when you check enough of these boxes, there's something that we need to make sure we're addressing. In my office, we bill medical for the sleep appliances. So we gather medical insurance cards just like we do the dental. I just have a little sign that says there are some procedures that might be covered by your medical insurance. So nobody asks questions. That they're used to me just gathering stuff. While we're on this, just a quick thought that came to mind. And I know a lot of doctors worry that team members are going to push back on having to fill out the Epworth or the stop pain questionnaire. Just because that's one more thing, right? Because patients. But empower your team, give them permission to blame you for it. And I say this with utmost seriousness because in my office, my team knows if you were to walk in and Christina hands you like 3 other forms after you being a patient of the practice for like 15 years, and you're like, really? She's going to have me fill out more? She knows to say, I know. Can you believe it? But she needs this just so she can take the best care of you. It gives her the information that she needs to tie in everything with your health, medical, your overall health, as well as your dental health. Would you please just fill it out? Because I don't want her to yell at me. And it's usually the team members that our patients fuss at, right? They have a problem with their insurance or their copay or what things cost or why they have to fill out one more form. It's never us that they have a problem with. So my team has permission to say, I want this information, and I will get upset with them if they don't get this from the patient. So they'll tell them, it's like, would you just fill it out? I don't want her yelling at me. And then I'll make sure to let her know. Or you can tell her when she comes in to see you. Never really happens. There'll be one odd duck that'll ask, like, why do you want me to fill out all these forms? And that gets addressed there. But it potentially could come up. So just make sure the team knows how to deal with this, how to address this, how to answer this. This is my practice. When I bought the practice from the dentist that was retiring, we were in three operatories, and we quickly outgrew the practice to there was a Blockbuster next door that went out of business, and I took over that space. So we were able to expand from 3 operatories to 8. And I currently have the luxury of having one sleep op that I only see it, that's only for adults. And then I have a second one that's only for pediatric sleep. That being said, if you have the space, great. If you don't, I still treated sleep out of 3 operatories. One thing I would encourage you to do is have posters or educational material that do talk about this. So you see there's that poster about the signs and symptoms of sleep apnea. That picture in the far corner of the football player, if you can see it, is Reggie White. It is, again, a conversation opener. I do not do sports, unfortunately. I could not even tell you what team Reggie White played for. But when patients come in there, they're like, "Ooh, Doc's a football fan." And it's an opener. It allows my team member to educate them about why I have Reggie White's picture up there. For those that don't know, Reggie White had sleep apnea, had a CPAP. The day he passed, he chose not to use his CPAP. He had it under his bed. And his wife is now a huge spokesperson for oral appliances, but it allows for those conversations. I also have a CPAP that was donated by a patient. He's like, "I have no use for this. I use the appliance you made me," with a mask. And patients look at that. We have one in our waiting area too. And patients are like, "Why does she have that there?" Again, allows for conversation, allows my team the opportunity to educate them on it. I have demo units of sleep appliances, because if I were to go into getting an appliance made, I want to know what it's going to look like, feel like. I want to touch it and turn it around. And is it going to poke? And is it going to be big and bulky? And what is it going to look like? So it allows the patients to see it's custom made. It's nothing too crazy, super comfortable. And it just eases their mind when we are able to demonstrate to them. I also have, that is an HST, it's the WatchPat, but this. I believe this was purchased online. I don't even know where it was, but you can purchase it online, and it allows, the lower jaw moves up and down, and it allows us to demonstrate to the patients what happens when the jaw falls back. The back of that tongue also falls back, and in that position, everything is closed, or the airway is super narrow, and then I move that jaw out of the way, and it takes the base of the tongue out of the way, and the patient sees I now have an open airway. Again, a lot of people are visual learners, because if I were to tell them, "Oh, your tongue's falling back and closing the airway," they cannot envision that. And I like to have educational tools, just one of those things. So we also have this to be able to share with our patients. In my office, this little guy is called Flat Stanley, if anybody has ever read those books, because it's literally yay fat. So we have Flat Stanley that demonstrates to our patients how repositioning the mandible can help open up their airway. Just some more, we have brochures for the patients, financing options, different appliances. And it all comes down to systems and protocols. Take the time when you are educating your team, when you're training them, to set up workflows. What is this going to look like when you see a patient in hygiene? What does it look like when you see a new patient? What is it going to look like when you have connected with a sleep MD and they actually send you a patient? That is my biggest source of referral, by the way. What is that workflow going to look like? What are the documents that you're going to need in conjunction with that Epworth? You're going to update your medical history form. Are you going to need a referral from the sleep MD? Is insurance going to need a prescription for that oral appliance? Do you need a form for medical necessity? What are the different forms that you're going to need to be able to do this successfully, consistently within the practice, and create an SOP around it? I cannot stress this enough. Actually write it down. Don't do it yourself. Most doctors are like, oh, one more thing I have to do. No, delegate this to a team member. Front office should create an SOP around what happens when their patient walks in. Assistants get to do it for what does impressions or scans and setting the position of the mandible look like? What is delivery protocol going to look like? What is follow-ups going to look like? Hygiene gets to have their own protocol. How are they going to have these conversations? What to do if the patient says this? Actually write it down and create a binder with it, because the goal is, if I were to walk into your practice and I knew nothing about what you do and how you do it, you could hand me the big binder and say, here you go, Meghna. This is how we do it. You could be here all day, but you're going to get it done right. So that's where creating those systems and protocols eases your life. While you're doing it, yep, it's a pain in the butt. But like anything new, once it's done, and it only has to be done once, it's smooth sailing after. So just make sure you're delegating time. The pushback happens when we tell the team this has to happen, and then regular dental office stuff still has to happen. So create those training time periods for the team to be able to go in and actually create this for you. And these two girls are my why. This is why I do what I do. Both my girls had sleep issues. I did not know this as a dentist. And this is where we're able to impact lives, not just those of our patients, but their families as well. And there's my email. Like I said, if you guys need those posters or even have any questions, just send me an email. I'm happy to answer those for you.
Well, thank you, Dr. Dassani. That was an outstanding presentation. So much good practical information. We have a lot of questions here. I'd like to go through as many as we can. We did go a little long today, but it was great information. So you started your discussion by talking about this is really a staff program that you said. I think you even said it was your staff's legacy. So can you talk a little bit about how you get your staff trained? You know, for all the folks here that would like to implement this kind of program, are there formal programs for your staff, or is this something where you did all the training?
I'm sure there are training programs for team members as well, but I always encourage doctors, you get trained. And then you get to set up a protocol and a system and a program that works with your office and your workflow. So the easiest way to do it is once a week, set an hour of training time. And say next week could be about how are we going to implement adding questions in our health history and revisiting that with our patients. That's one protocol. Following week could be how are we going to answer the phone call, or how talk to patients when they ask front desk about it. Just breaking it down into bite-sized pieces allows the doctor to create their own protocols to be able to bring the team on board. Team is much more receptive to sleep than we think they are. They just need guidance.
Yeah, I what I found too is, of course, the staff learns a lot from listening to you talk to the patient, right? So they kind of absorb a lot of what you're saying. And also they're so good at this because the patients are so comfortable talking to staff members, more comfortable than they are talking to us. So I love what you're saying. But you're not familiar with any formal type of programs that staff could go to, if somebody's interested in that.
Most I know is that will train the doctor, and then the staff is able to attend those as well.
Exactly. Like when we had our sleep symposium, lots of doctors brought their staff with them, and they can absorb it there. So great stuff. Now, you mentioned that physicians were your best source of referral, and we had a couple of questions about how do you get this relationship rolling? Any hints for building that relationship?
That's the space where a lot of doctors get stuck. And my answer to that is you've got to kiss your frogs before you find your prince. It's it's as simple as making, how I did it was I Googled like sleep physicians near me. We made a list of the 30 doctors around us, and I would go knocking on doors. It's like, hey, doc, we treat sleep within the practice. And here's the big but that I came across. I find, even when I coach doctors, like people will go to the sleep MDs and say, I need sleep appliances, send me your patients. And they're like, I don't know you. Like, why would I send you my patients? I find the easiest way to do this and to build that relationship and trust is saying, hey, doc, we've been screening for sleep in my practice. And yes, I do make sleep appliances, but a lot of these patients need sleep studies. How can I send you my patients? I'm not asking you for anything. I'm sending you my patients. And even they know their patients are not compliant with the CPAP, and that creates that back and forth relationship.
Are most sleep physicians familiar that dentists are treating this condition, that dentists can make a very helpful appliance?
They're coming around. It's much better than what it was when I started. There's more awareness. More of them know that we can help the patients, but there's still a lot that don't, which is why, like I said, you got to kiss those frogs.
Okay, I got a couple of clinical questions for you. If you put a patient on a mandibular advancement device and they start having an open bite in the posterior, how do you treat that?
So when you deliver a mandibular advancement device, you should have had delivered an AM aligner at that time. And what that AM aligner does is it resets their bite to normal every morning, because we're holding that lower jaw forward. And that's where the jaw wants to sit. It's been held there. So if we don't give them that AM aligner to kind of get it back to MIP, CO, whatever it is that we're calling it, you are going to end up with the open bite.
I think that's something a lot of people don't understand, that change in bite is not the teeth moving, right? The teeth can't move. You've got a retainer on the upper and lower, so the teeth aren't moving, right? What's happening is there's some fluid getting into the joint. The joint is positioned a little differently, and the AM aligner that you talk about is something that the lab can make you when they make the appliance, and get your patients trained on, hey, you jump in the shower, put that AM aligner in, and get those jaws realigned, and it's something they've got to do. And then, you did a beautiful job talking about the relationship between OSA and some of these chronic medical conditions. But we did have a question about the relationship between OSA and diabetes. That's not a really intuitive relationship. Can you tell me a little bit more about that relationship?
Like I said, there's studies out there that show that, and that 15% number stands out. And at the end of the day, the bottom line is OSA creates inflammation within the body. It's closely linked to metabolic syndrome and, the effect that it has on the heart and all of that. It's just an overall impact that has had.
And one may not cause the other. They just seem to be correlated.
Correct.
Exactly. Yeah. Oh, and just for everybody out there, Nicole has decided that you're all going to get 1.5 CEUs for this program, because we are going over a little bit of time. And I've got a lot of questions about insurance. You touched on it briefly, but I think the best thing to do is we're going to bring in Randy Curran for a lecture, and he's really an expert on how to make this happen. So we're not going to handle that in the questions today. So here's another question for you. I've got a patient that they was screened, and we suspected, they have several positive markers for OSA, but they said they had a sleep study done X years ago and everything was fine. How often should that sleep study be repeated if we have a lot of tendencies to believe that they are sufferers?
And again, I know you mentioned bringing Randy on, and I think he will be able to answer that as well. But currently, if you're trying to get that diagnosis, how medical insurance will cover it is you need to have a sleep study within the past year. It used to be 2 years. I think current is within the past year. And the reason I bring up medical insurance is because things change. And I said, we go to our doctor, we go to dentist and ENT and cardiologist all in the same day. Things change. Has there been weight gain? Has there been any new medications that this patient has been on? Any other life changes? Women, are they pre or perimenopausal? We know estrogen levels are going to impact all of this. So there's a lot that goes into it that we need to consider.
Right. So if there's been changes, even just time going by, repeat that study. Great idea. This was a wonderful discussion. Your style is so conversational. You really talked about things that are happening in your office. I know I learned a lot today. I really appreciate the lecture and your style and the way you brought all of your experience to us today. So thank you so much, Dr. Meghna Dassani. We appreciate it. We are looking forward to having you back. And thanks everyone for joining us today. We appreciate you coming, and we look forward to having you back next week, when we'll have, as always, our business advisory panel. And our guest speaker will be Dr. Tim Kaczynski, and his topic will be tips for success with grafting and suturing. Always a lot of good information. So let's meet back here same time next week, and everybody have a terrific week. Take care.